Dr. Curley, welcome to the podcast. I'm so excited we're finally able to make this happen, man. For people who aren't familiar with you and your practice in Delaware that way, would you mind filling them in a bit about who you are and all the amazing things you're doing down there?
Yeah, thanks for the for having me on the podcast. It's good to connect with you again. So I'm a orthopedic surgeon in Southern Delaware. I'm trained in fellowship trained in sports medicine, and I did additional training in robotic hip replacement and hip preservation surgery, which includes hip arthroscopy. My practice is a blend of knee, shoulder, and hip surgeries. I do arthroscopic surgeries on all three of those joints. And then in addition to that, I do hip replacement and shoulder replacement surgeries. So kind of a nice blend of, athletic injuries as well as degenerative injuries that we take care of in kind of a wide population of patients.
Absolutely. Yeah, no, it seems like you do a little bit of everything that way. And having seen some of your patients, they all always have such great things to say about working with you and the overall process of just getting in to see you the first time that way, which is always a good thing to hear about that way from, people that are working with you. And as you mentioned, your practice kind of blends that sports medicine element and you've got additional training in that with some of those different I'll call them like lifestyle procedures, if you will, where we consider maybe like the older adult looking for a hip replacement or a shoulder replacement. Like you kind of get to do the best of both worlds, in my opinion. And it's funny because I think historically we look at arthroplasty and we look at arthroscopic procedures like ACL or meniscus repairs, hip labrums, shoulder labrums, that sort of thing. And we almost think them as separate things of like, hey, this is the sports med, the athlete side. This is the arthroplasty, the older adult side. But now more than ever, I'm seeing the two worlds almost collide to the point where we're seeing 30 and 40-year-olds getting joint replacements. And those individuals are not just getting them to get back to day to day. They're like, hey, when can I go back to water ski? When can I go back to play baseball? When can I go back to doing sporty athletic things that I think for a while, at least for myself, I didn't necessarily consider as possibilities within the arthroplasty world that way. I'd love to hear your thoughts, first of all, on this concept of kind of pushing the envelope, if you will, with arthroplasty into athletics that way, where people are seeking shoulder replacement or seeking hip replacement from you. And it's like, hey, I want to get back to something active and sporty and not just kind of walking around on the day to day.
Sure. Yeah, no, that's it. It's a hot topic right now in medicine, that's for sure. And medicine's continuing to evolve at this point. The technology continues to get better, innovations continue to come out. And as medicine evolves, I think the goals and expectations of patients, they continue to evolve as well. So whereas, what a patient expected maybe 15, 20 years ago, it's a little bit different than what they're expecting today. Oftentimes they can go online and see what some other patient is doing. Social media is changing that as well. Everybody's posting their recovery, things like that. So, they see a great success story of somebody, across the country doing X, Y, and Z, and that's sometimes their level of expectation coming into the office. So I think it's important to know kind of what the patient's activity level is, what their goals are, and help them achieve those goals. Sometimes, if that expectation level is just not achievable, their condition is just not amenable to going back to that level of activity. It's important to flesh that out early on and set expectations. But obviously, if a patient wants to get back to an activity or a goal, and we can do that, that would be our mission for that patient. You bring up a great point, with, for example, the patient going back to water skiing after a hip replacement, I believe you said. Um, the implants that we're putting in now, the wear properties for some of these polyethylene components, it's way better than what it was 20, 30 years ago, and the technology is continuing to get better. So people are pushing it more and more. I think it's worth having a discussion, if that's your goal and that's what you want to get back to. Yeah, there's obviously risks of pushing an implant harder than somebody that's just walking around on a day-to-day basis. But that patient, with their goals and their lifestyle, they might be willing to accept a lot of those risks and potential outcomes if they get to do something that they want to do for the next 15, 20 years. So it's definitely worth the discussion.
Absolutely. Yeah, and you mentioning that, historically, I think a lot of these implants, they were expected to last 20 to 30 years, but from what you just said, it sounds like we're pushing the envelope on that to the point where maybe some of these implants are going to see 30 plus years of use before need for a revision that way.
Sure, yeah, and, yeah, there are some implants out there where, hey, potentially 30 years, and it's tough to say because keep in mind a lot of the studies that we're looking at now that have 20 and 30-year follow-up, they're from implants that were put in 20 or 30 years ago. So, the implants we're putting in now, by the time we have 20 and 30-year follow-up, it's going to be way down the road. So maybe 30 years will be the norm, at that time, and we'll be looking for something with 40-year longevity or something longer at that point.
Absolutely, yeah, and you mentioned about different times where, hey, maybe there's a discrepancy between what someone wants to be able to return to do, versus, like, the status of their condition that way, and as you were talking, the first example that popped to mind for me would be someone who wants to do something throwing or overhead related that needs a reverse total shoulder replacement, right? Where we have a complete deficient rotator cuff, and it's like, "Hey, we're gonna do the reverse total shoulder because that's our best option at this point." Like, I can see that as maybe being a little bit of a discrepancy that way. Are there any other kind of like unique examples that you've seen clinically or just kind of think of that way where it's like, hey, I know you want to get back to X, Y, and Z. However, this is the unfortunate reality of where we're at this point.
Yeah, I think for every surgery, there's always an activity that when a patient wants to get back to it, you're always having a longer conversation with them and letting them know the risks of that. With any kind of arthroplasty surgery, anything that's high impact, repetitive, you worry about it wearing down the implant over time. For reverse shoulder arthroplasty, yeah, range of motion is certainly it's something that I talk to patients about, what they can expect after surgery. And as you know, rehabbing a lot of these patients, the range of motion outcomes after reverse shoulder replacement, it's somewhat unpredictable. The surgery can go great and everything goes well. And sometimes they just have less range of motion than another individual that had the same exact surgery. So that is a conversation I have with patients in advance. Another one that comes to mind, let's say, we're doing hip arthroscopy for hip impingement and somebody's a power lifter and they want to go back into deep flexion squats. It's just a tough position to put on the hip. And, you can do a great surgery, repair the labrum, address everything inside the joint, but it's just a very demanding position to put the hip in. And you just run the risk of recurrent symptoms. And once again, it's not necessarily a deal breaker, but it's a conversation that you have with the patient before surgery or going down that route of treatment.
Yeah, no, I think that's really well said, and it's funny because there's certain positions that it's like, you definitely wanna avoid the extremes of them for quite some time that way, and I know it's a little bit different for, like, hip versus shoulder and what type of, replacement you, do that way, whether that's maybe like an anterior approach in the hip versus a posterolateral approach for the hip that way, but I know thinking back, geez, like 5, 6 years ago, going over some of those different precautions and some of the extreme positions that maybe you want to avoid. It's like, if you're going to go through one of these procedures, unfortunately, like you're not going to be like one of the Rockettes hitting these like extreme, unique positions that way, unfortunately. If you do, like, hats off to you, my goodness. But I think it's to your point, putting into perspective, like what's very possible to happen versus like what might be a little bit of a reach. And I think some of those extreme type things might be a little bit of a reach, especially with the arthroplasty in mind, like you said.
Yeah, I agree with you. And to go back to one of your earlier points that you brought up, we oftentimes think of arthroscopic surgery and arthroplasty surgery on different ends of the spectrum, but oftentimes there's patients that come in somewhat in this gray area where both are reasonable options. And a couple examples I could give you would be a patient with mild degenerative changes in their hip that's more active, who they it would be worth a discussion of hip arthroscopy versus a hip replacement. We know hip arthroscopy for folks that have advanced degenerative changes, the outcomes just aren't quite as good. But maybe their hip isn't completely bone on bone arthritis. They're younger. They have a higher activity level. And there's an issue intra-articularly that we can address through the hip scope. So that's a patient that falls somewhat in that gray area where I think it's worth a discussion of both surgeries. Another example of that, you brought up the reverse shoulder replacement. Maybe there's an individual with a massive rotator cuff tear, and we're looking at the MRI together, and it's a question of, hey, can we repair this rotator cuff? And you can look at the MRI and all these preoperative factors, but at the end of the day, oftentimes you don't know until you get there in there intraoperatively, and you see how pliable the rotator cuff is, what the tissue actually looks like when you're directly visualizing it. So a patient like that might be borderline for a rotator cuff repair versus a reverse shoulder replacement. They both have their risks and benefits. So, you got to talk with the patient, see exactly what they're looking to get back to, what their threshold is for risks, and let them know, hey, there's a chance that if we pursue this arthroscopic surgery, you may need a secondary surgery down the road for conversion to an arthroplasty surgery. And some patients are fine with that. Other patients, they come in and they more so just want one surgery and to be done with it.
Yeah, and I can certainly appreciate both ends of that spectrum as well, right? Like on one hand, I like the concept of being in once and out that same time, but on the other hand, I also like the concept of maybe delaying the need for arthroplasty as well. As we mentioned earlier, we expect it to be a 30-ish year lifespan of these implants that way, but if I'm 45, there's a pretty high likelihood I'm going to need another implant, a revision of that arthroplasty later in my life that way. So delaying that could be valuable. The other thing that I find interesting about what you just brought up is a lot of the essential conversations that need to happen with the patient to help steer that down the right direction early on and make a more informed choice, in my opinion, are highly dependent on the imaging that you have. Because if you're having a very difficult time visualizing what you need to see from MRI and other imaging modalities, it's like, hey, look, we almost have to kind of like go in and see what we see and then go from there. But by that point, the patient's already asleep. They're not going to be able to give that same level of decision making in the moment as they would if they were maybe a little bit earlier on that way. What does your kind of imaging workup look like for the hip and the shoulder that way for these kind of conditions that we're talking about? And how does that kind of help you decide which route to go on the scope versus arthroplasty debate for them, if you will?
Sure. Yeah. That's a great question. Oftentimes, for a lot of these soft tissue procedures, we want an MRI to look at the soft tissues, so things like the rotator cuff, the labrum, in both the shoulder and the hip. With that being said, there's different MRI facilities. Some facilities have better resolution than others. A patient might have claustrophobia and they come in with an MRI that's already completed with an open MRI, where oftentimes the resolution just isn't quite as good. So, it's there's a lot of factors that you're balancing. And then, in addition to an MRI, do you add contrast? Do you add IV dye? I'm sorry, not IV dye, but dye intra-articularly into the joint to help, with the resolution, the MRI for certain pathologies. That's another thing that we consider. So there's not necessarily one cookie cutter answer, because sometimes a patient already comes in with an MRI and the resolution's good, and it's a study that we can see what we need to see. Sometimes we might need to get a repeat MRI or get a new first time MRI with a specific protocol looking at those specific pathologies. And I have certain hip MRI protocols and things like that really dial in on looking for the things that we need to see, maybe getting a more close-up view of the hip joint itself rather than getting in a whole MRI of the pelvis where things are zoomed out a little bit more.
Yeah, no, I think that makes a lot of sense. And it's interesting. I've had a lot of conversations with clinicians lately who are almost trying to bridge the gap between the X-ray and the MRI with some type of musculoskeletal ultrasound or a diagnostic ultrasound to kind of visualize some of those different soft tissue structures before they go and send for, what I like to call magnet therapy that way. Have you seen diagnostic ultrasound infiltrate your own clinical practice at all that way? And do you feel like there's a value in that clinically, or are you someone who might just kind of fall into more of a camp like me, where I think at the end of the day, the MRI is just the best to have because it's like the decisions are going to be made off the MRI. So like, why waste our time with other scans when it's like, this is the thing that's going to decide our course forward, if you will?
Yeah, that's a great question. Is there a role for ultrasound? Yeah, I'm sure there probably are certain instances where an ultrasound might be a reasonable option. With that being said, ultrasound is oftentimes dependent on the tech that's administering the ultrasound, and there's some really great ultrasound techs out there that have advanced training in musculoskeletal ultrasound. They can get great resolution of the joints, and it gives you additional data points for what you're going to decide for that patient in terms of treatment. With that being said, in my practice, we don't utilize a ton of ultrasound. Just kind of with where I'm at and the resources that we have available where I'm at, it's just not something that's commonly utilized. That's not to say that that wouldn't change in the future or there wouldn't be a role for that in the future. However, if we're ultimately going to the OR and we're planning to take the patient to surgery, I do feel I like to have an MRI. I like to have as much information as I can prior to going to the OR. So even if we had a great ultrasound that had a ton of great data points, I would want as many data points as I could. I would want that MRI just so that there's no surprises that could have been avoided prior to going to the OR.
Yeah, no, and I think at the end of the day, that's the thing. Now more than ever, patients are becoming more and more educated, whether that's through the powers of Google or Chat GPT or whatever. Like patients have more of an understanding of what's going on in general than they did before. And I think a lot of times when they're doing these searches, the thing that comes up over and over again is MRI is the gold standard. So naturally, they're looking for that. That's almost like an expectation I've seen now in the modern healthcare system, where if you have some kind of orthopedic problem, especially if it was traumatic in nature, people are almost expecting that they're going to get an MRI ordered and they're expecting that they're going to get that in a somewhat timely manner that way. And it's not to say, to your point, it's not to say that there's not value in diagnostic ultrasound, but I think it's one of those things that now more than ever, there's this growing patient pressure. I mean, I even felt it in Maryland because Maryland allows PTs to order their own diagnostic imaging, which is a huge blessing and a curse. I'm going to avoid some of my personal opinions on that, but like people, they once they find out about that, there's certainly pressures to get answers, and they know that the MRI is kind of the way to go about that with certainty, if you will.
Yeah, and I agree with you. And and just to take it in a different direction, yes, MRI oftentimes is the gold standard for looking at a lot of things, but it's not uncommon that, let's say, a patient comes in with an MRI that they didn't necessarily need. I've seen a patient come in with an MRI of their hip. They have, I get an X-ray of their hip. They have advanced bone-on-bone hip arthritis of their hip, and they come in with an MRI that says, "Hey, there's a labral tear in my hip." So part of the conversation is oftentimes kind of walking them back a little bit and letting them know, that labral tear isn't necessarily your issue. It's the underlying problem of the arthritis inside of your hip. And for a patient like that, oftentimes the MRI didn't really change management. If a patient comes in with advanced arthritis of their knee or their hip, that's not a patient that we're typically ordering an MRI on unless we're looking for something outside of that arthritis. Um, so MRI is the gold standard for a lot of things, but there certainly are plenty of conditions where just regular X-rays help with the diagnosis along with clinical exam.
Yeah, absolutely. And it's interesting to me because as you were talking, my head was going back to some of the different reports that I was seeing, more commonly with the knee than anything else, that would have 8 to 10 findings on them. And it's like, oh, there's mild quad tendonitis, mild patellar tendonitis, there's mild, mild effusion, there's a Baker's cyst, there's like all these little things. And the patient will bring that in and look at the laundry list in front of them and they'll be like, wow, I really messed it up. Like this is a mess. And it's like, of these 10 things, only one or two actually pertain to what your orthopedic provider is going to be talking to you about. Like I'm sure if you MRI'd a number of athletes, there's going to be mild tendinopathies and a lot of them. There's going to be like, if you have some type of injury to tissue that causes instability, I would expect a certain percentage of those cases have some kind of cyst-like formation because of that instability. Like there's certain findings that I understand why they're noted, but by the same time, it just makes it so much more difficult for the patient who's just trying to make sense of everything that they just had happen. It kind of creates this confused picture for them.
No, I agree with you. And another example I would add to that, let's say I'm getting an MRI on an individual that has a rotator cuff tear. And the MRI report might show that they have arthritis of their AC joint, and they have no symptoms whatsoever in their AC joint. They come in saying, "Hey, I have arthritis in my shoulder." And once again, we kind of need to, educate a little bit that plenty of folks have arthritis of their AC joint on X-ray, on MRI, that have no symptoms whatsoever. And that's not your underlying problem. Your real issue might be this rotator cuff tear that you have there. So, it's great that, access to care is continuing to improve. The electronic medical record continues to get better and better, and patients have access to their records. But oftentimes, if you get that report in advance without someone to help you kind of interpret it and go through the findings together, it's easy to get confused for what's really causing your issues, and coming up with the best treatment plan for you.
Absolutely. And once you've got that kind of treatment plan in place, going back to the hip, for example, you brought up the hip earlier and you brought up impingement, and impingement of the hip is one of those things that I always hyp- hypothetically think impacts a lot more people than the statistics show. Like, I think certain studies show like 10 to 15% of adults have hip impingement. And for some reason, I just personally feel like that number is significantly higher. And again, that's just based on my own anecdotal kind of practice that way. Where do you like to go? Because before you mentioned about the arthroplasty versus arthroscopy of the hip that way. And I think it's one of those things that to a certain extent, a lot of these things I've seen resolve within rehab themselves, but there's also a number of pesky cases that aren't better after months and months of rehab. And it's like, hey, look, like if you've already got impingement going on, obviously we know there's a tie there with the labrum pathologies of the hip. And I believe, correct me if I'm wrong, but I believe recovery from just impingement type procedures a little bit easier than if we have to recover from sutures through the labrum as well. And then on top of that, just kind of like a follow up, if you will, that way. How many of the hip issues that lead to arthritic changes do you feel kind of fall into that impingement labrum bucket versus the dysplasia bucket, if you will, that way as like a preceding causative factor, if you will?
Yeah, it's a great question. There's multiple facets to that question, and the traditional teaching for when we look at a younger individual with hip pain that's truly coming from the hip joint, two of the better defined reasons for having pain within the hip joint are: number one, you have impingement, and the classic types of impingement that are described are cam and pincer impingement, where essentially you have extra bone on the ball side of the ball and socket joint, or on the socket side, and that extra bone, it leads to impingement in the hip and the labral tear and degenerative changes. That's one classic example of pain for a younger individual. The other end of the spectrum is you have too little bone in the hip, and that's dysplasia, where the socket's a little bit more shallow than the average person. That leads to abnormal joint mechanics and leads to early degenerative changes in the hip. And conceptually, it's easy to wrap your mind around both of those concepts because they make sense. But quite often, patients don't fall neatly into either one of those categories. They might come in with impingement type symptoms and their radiographs look normal, or they might have instability symptoms with a normal appearing socket of the ball and socket joint. So, we're starting to get better and better at looking at some other tertiary factors. And, some new things that have come up are, for example, femoral version. So if someone is anteverted, their femur is anteverted, they might be at a higher risk of instability, versus a retroverted femur might be at a higher risk of impingement. Other factors, the pelvic tilt. So, some folks, just the way that their pelvis tilts, that could predispose them to impingement or instability. And, once again, a patient could have symptoms of both. They could have impingement and instability. So, the waters get murky pretty quickly when a patient doesn't neatly fall into one of those two categories. And, one of the things that you touched upon is, there are folks that you send to therapy and they get better, and other folks don't. And, I think that's one of the more interesting things about hip pain in younger individuals. And we don't truly, I think, understand yet who does get better from physical therapy. There certainly is a cohort of patients that do get better. but it's been tough to define, and yeah, I think that's something that we're still looking to research and better define in the future. Of a patient might come in with this type of morphology, this type of anatomy, they would do really well from physical therapy versus this other patient. Maybe they're just not as likely to do well from physical therapy, and maybe just treating it quicker surgically might be a better option. I think that's something that we could better define in the future. One thing, for example, with therapy that you might address is, let's say a patient comes in poor core strength and poor pelvic stability. Maybe addressing some of that pelvic stability that might realign their pelvis a little bit so that it's not impinging, or it might give them more stability for that hip dysplasia patient. So I think that's one example of a patient that could improve with therapy. When someone comes into my office, yes, I pretty much almost everybody is getting some form of physical therapy before I would consider surgery for that younger patient with hip symptoms, because in the event that patient can get better with therapy, you just save them a surgery. So I think there's little downside to trying it, but once again, it would be great to know in the future just better predictive qualities of who is truly going to do better from therapy versus who would do better from surgery right away.
I 100% agree. If there was some kind of like, I know there's a lot of clinical prediction rules out there, but I haven't seen one on the hip as far as like for some of these different pathologies, impingement, labrum, whatever, who's going to respond well to conservative management versus who isn't. And I remember having this discussion with a couple other surgeons in the past, one of whom is, I know a good colleague of both of ours that way in the Baltimore area. And he said he couldn't figure it out. He's like, he'll have 5 patients, all will have hip labrum pathologies. He'll send them all to rehab, and in 6 weeks, the 2 that he didn't think were going to do well in rehab end up saying they're great, and the 3 he thought were gonna crush it are now asking when their surgery date is, and it's like, it's just so unpredictable in nature, and it's interesting because even when we did a podcast diving deep into the hip rehab side of things with Keelan and Seki, another pit guy that way. I think he's one of the director guys within the UPMC world, puts out a lot of great research on the hip that way. And, we talked about it and he's like, there's nothing yet. We're getting closer, but we're not there yet where it's like, hey, this is the formula, this is the algorithm that way. To your point, I think there's certain things that every rehab provider should be assessing when they get these patients in for the hip. You mentioned core, you mentioned pelvic position. I also really like just the overall hip range of motion and hip strength and what kind of acute change can I have on those things, right? Because a lot of times people come in and they might have limited hip rotation, but it's like if you can free that up in 5 to 10 minutes and get them an extra 10 to 15 degrees, to me, that's a really good sign. Like, hey, we can have an impact on this in a very short amount of time. To me, that's more of a this is going to do well sign than a this is not going to do well sign that way.
Yeah, I think
And
that's just a jump in there. I think that's a great point. And a lot of what you're assessing there is kind of a dynamic range of motion or a dynamic assessment. And at the end of the day, a lot of these impingement issues and instability issues, it's a dynamic problem. It's the way that the hip is moving in time. As a clinician, when I'm seeing a patient in the office and I'm looking at their X-rays and their MRI, it's a static image. I'm seeing that bone at one place in time. I'm not seeing how it moves in relation. And things like femoral version and pelvic tilt, those things address how the hip moves dynamically. So I think oftentimes we're taking a static imaging study and trying to interpret a dynamic problem. And I think that limits the predicted value. As the technology gets better, maybe there will be a better dynamic imaging study where, there's dynamic ultrasound or some sort of dynamic X-ray that you can see the hip move in time, and that would give you a better predictive ability. But I think you nailed it on the head with your dynamic assessment. I think that's a critical data point for evaluating how a patient is going to do.
absolutely. And I think the other thing I had previously undervalued, I would say, is the role of the lower back and the role of the neural components within the hip as well. As I think a lot of times I'd have someone sent to me and it would be, a hip diagnosis, ICD-10 code. They'd have imaging that supports hip pathology. And I'd kind of say, well, look, it looks like a duck. It walks like a duck. It's probably a duck. But there are certain patients where I noticed they weren't getting better within, I would say, a month, 4 to 6 weeks. We're not seeing notable improvement. And a lot of the times it ended up being more of a lower back type of pain referral. And that's not to say there wasn't something mechanically wrong with their hip, but I think a lot of the symptoms that they were complaining of were actually coming from the back and not the hip. And, we mentioned the shoulder earlier. I see the same or a similar type of thing with the shoulder a lot of times as well. It's not to say that there's not pathology within the shoulder. There more than likely is, but I think a lot of times there's some value in even looking a little bit more proximally at the neck, at the thoracic spine, and at some of those other regional kind of components that way to clear those up. And again, this bridges that gap again with the athletics versus the arthroplasty conversation as well, because regardless of if someone had a joint replacement or if they had a scope or if they're just strict conservative management, if they're not performing at the level that they want and they've got pain, they're not going to be playing the sporting activity that they desire. So if you can clear those things up for regardless of which one of those three patient populations it is, they're going to be very appreciative of you, I think.
I couldn't agree more. And yeah, there certainly is an overlap between the back symptoms and the hip symptoms. And like I mentioned earlier, patients don't always clearly fit into one neat box. They might have symptoms of both a hip and a back thing, a back issue, and you need to spend some more time flushing it out. And another factor I would add in there is there's also intra-articular and extra-articular hip pathology. They could have trochanteric bursitis or a gluteus medius tendon tear on the outside of their hip, with overlapping symptoms as well. So oftentimes, it takes some detective work, and it's not one clean MRI or one clinical exam test that confirms the diagnosis. It takes a series of tests. You got to really listen to the patient, see where their pain is coming from. An additional, once again, to use the term data point that we can get for oftentimes diagnosing, hey, is your pain truly coming from the hip? Especially if I have a patient that, they might have symptoms radiating down the leg, it's concerning for a concomitant back issue, is, I'll send the patient to get an injection inside of the hip joint itself. So if that injection clears up their symptoms, we feel a little bit more confident the pain's coming from inside the hip joint itself. Versus, if it doesn't clear up their symptoms or they don't get any temporary relief from that, it gives us reason to pause and say, hey, let's look elsewhere. Let's dig a little bit deeper into the back or outside of the hip. Let's see, could that be contributing more to your symptoms rather than something inside of the hip joint?
And it's so great to bring up the intra versus extra articular pathologies, because I think a lot of the times we forget about the extra articular ones, or at least I've fallen into the trap of forgetting about all of the other structures that are outside of the joint capsule itself, and even the role that they play within the joint capsule. I think I believe it's the rectus femoris muscle attaches to the hip joint capsule itself that way, and it's like, when we think about the intra-articular component, also think about all the other structures around there that directly impact that. Like if a tissue attaches directly to the capsule, like don't be afraid to assess that if nothing else. And I also am curious if you have someone who's kind of got maybe a combo of both, where it's like, hey, intra-articularly, we definitely need to do something. We need to scope it or we need to replace it, which I know you mentioned you do robotically that way, but there's also some extra articular stuff. Now, obviously, some of that, like if there's tendon tears, maybe that can be addressed while you're in surgery. But some of the other stuff, like if it's a bursa type thing, or if it's just some type of friction type pathology, if you will, or a snapping pathology, it's like, what is the surgical treatment for some of those things? And is the juice worth the squeeze on that? And if it's not something that you address surgically, you expect a lot of those to almost self-resolve because of addressing the intra-articular issue. Like perhaps the intra-articular issue is also contributing to the extra-articular pathologies, or do you see it more as the opposite, where the extra-articular stuff may be accelerated or contributed to the breakdown that we see intra-articularly?
Yeah, I think it's a bit of a chicken and the egg question. I don't think we truly know the answer sometimes for a lot of these patients. But, for example, let's say, a patient has instability type symptoms of their hip and their gluteus medius is working on overdrive to provide that stability to their hip. You would say, yeah, there's an intra-articular issue that's leading to gluteus medius tendinopathy on the outside of the hip. That'd be one clear example. But oftentimes it's just not that clear. Yes, I've seen both where a patient, they have symptoms inside their hip joint, but when I push on their trochanteric bursts on the outside of their hip, they're pretty symptomatic there as well. So there have been some cases where they failed the non-surgical treatments. We end up moving forward with surgery, and we'll scope both the inside of their hip and the outside of their hip at the same time. When we do a hip replacement, oftentimes we're looking at that gluteus medius muscle while we're in there. So sometimes you can see, hey, they have a tear there of that gluteus medius muscle. Some surgeons will repair that. Other surgeons will kind of let that be and focus more so on the inside of the hip. So there's a couple different approaches, and I think if you ask a couple different surgeons, you're going to get different answers for what to do there. It's just not clearly defined, but it is interesting to see how all these components interplay with each other, and it's certainly something that we think about and we consider. Hey, if we're moving forward with surgery, do we address all of these things? Do we focus on the main issue and see if the secondary issues resolve on their own?
Yeah, yeah, no, I like that chicken or egg analogy that way. It's like sometimes we just don't know as much as we want the definitive answer, and everyone throws around these root cause type terms that way. But sometimes it's like, hey, look, there's 20 different things going on here. They're all contributing. It's not just one of them. It's like all of it is kind of mixed together in this picture. It's not as clear cut and simple as we want it to be. And one of the other complicating factors I've seen from return to sport in these populations is when it's not just one joint that we're talking about. A lot of individuals nowadays are getting one joint replaced or reconstructed, and then maybe 6 months later, they're getting the other one done. And they're like, yeah, I just want to knock them both out same year for one reason or another. Maybe it's deductible, whatever it is. It's not my place to judge, but it's like, hey, look, if we're knocking both of them out in the same year, to me that changes what we're looking at from a return to sport side of things, because it's like, well, historically we always compare a non-involved to an involved side, but in this case, hey, both are kind of involved when we're reconstructing both the left and the right. And it doesn't matter if we're talking shoulder or hip. It's this again, I think people want it corrected, they want it right, and they want it right sooner that rather than later, so they can get back to living the rest of their life that way.
Yeah, and I've seen it go a couple different ways where, let's say a patient comes in with arthritis in both of their hips, and we might do a hip replacement on one side, and it feels so great. They want to get the other side done right away. On the flip side, I've also seen it where, hey, we do, a hip replacement on one side, and now they're able to start putting more weight on that side. It feels better, and the other side doesn't hurt quite as much because it doesn't have to bear more of the load. So, patients can go a couple different ways in terms of, do I want to, get the other side done right away? And yeah, it's more than just treating one joint. You got to look at their whole kinematic alignment. When you affect one joint, it doesn't just affect that joint; it affects the back, the other side. The body as a whole responds to that surgery. So you have to take all of that into account when you're treating these patients.
Yeah, how do you go about on the alignment side of things that way for the hip? I've heard a lot of different things from different providers that way, from leg length and beyond that way. There's so many variables and factors I think that go into your line of work, and even just deciding your surgical approach. Like, I believe, correct me if this is wrong, but I believe a lot of the robotic stuff is done anteriorly through the hip that way, so that you avoid a lot of the soft tissue structures that way, if you will. But I'd imagine there's a lot to consider when you're doing one of these hip reconstructions that way.
Yeah, and so you can do robotic hip replacement both anterior and posterior. So you can do it from a multitude of approaches. I do anterior robotic assisted replacement. That's the approach I was trained on. It's the one that I'm most comfortable with. So that's the typical approach that I offer for my patients. And in terms of things like leg lengths, yeah, we oftentimes try and match the leg lengths up as close as we can. But let's say, for example, a patient has a significant leg length discrepancy where one leg is significantly shorter than the other. If you lengthen that leg too long, you could, set that patient up for another issue like a femoral nerve palsy because you stretched the leg too long. Um, a different example might be, let's say a patient has advanced arthritis of both hips. You talk to with that patient that, hey, we're going to do surgery on both sides, and you're doing the surgery, and um, perhaps you matched both leg lengths up on the first surgery, and you're trialing the components, but it just feels a little bit loose, and you want to give them a little bit more stability. So in that case, you could potentially go up a size. Lengthen the construct, just make their hip a little bit more stable, knowing that their leg length might be a little bit longer for a couple of weeks or months until we come back to do the other side, and then we'll do the other side, lengthen that side as well to get them back to equal. So it doesn't always, it's not always a clear picture of, hey, we're going to go in, we're going to match the leg lengths up directly for everybody, every case. Oftentimes that is the case, but there are numerous exceptions where it might be better to do something different with the leg lengths to give the patient a better outcome.
Yeah, no, I like that a lot. I like that a lot, Andrew. And how about for the shoulder that way? Obviously, we talked a little bit about the reverse total shoulder previously, in the rotator cuff deficient individual, but I would assume odds of return to different activities, whether that's kayaking and canoeing or swimming or something like that, if you have an intact rotator cuff, you're going the total shoulder route. I'd imagine for a number of individuals, return to activity rates are pretty good, even if it's something that ends up needing bilateral type of procedures that way. And on one hand, I like to think that there's as many factors, if not more factors, with the shoulder as the hip. But on the other hand, I think about some of those things like limb length discrepancy, and to me, like the upper extremity might be less impacted by that than the lower extremity. But in relation to like anatomically the nerves and amount of vessels that are within the shoulder that way, there's a lot in play as well. So
Yeah, there's certainly different factors. For going back to hip replacement, something like limb length discrepancy might be, a larger issue or a larger factor for deciding, how we're going to proceed with surgery and what we decide to do intraoperatively. For upper extremity surgery, small variations in limb length, patients don't commonly notice that. So, rather than being necessarily quite as concerned about limb length, it might be soft tissue tensioning around the reverse shoulder replacement or the anatomic shoulder replacement that we put in. So, there's different sizes components that we put in. You could put in larger components, which give the construct a little bit more stability. But there's a trade-off that if you put in something that's too large and too stiff, you could lose some range of motion. So, it's different factors for different joints. And, even within the same joint, doing a reverse shoulder replacement versus an anatomic shoulder replacement, there's multiple things that we're looking at to ultimately give the patient the best outcome.
are there any structures as you do these replacements that way that are left intact afterwards in relation to what was natively within the joint space that way? Like I think about some of the advancements made with the knee arthroplasty and how there's cruciate ligament sparing options now that maybe didn't exist previously. And I'm thinking about like in the hip, like, we've got these different ligament constructs like iliofemoral, ischiofemoral, and I guess I'm wondering, like, do those stay in place or are those, removed in relation to the process of the reconstruction or the arthroplasty? And then obviously same to the shoulder as well, is like how many of those different supporting structures are left in place after the arthroplasty procedure?
Yeah, I think one example for would be the shoulder, reverse shoulder replacement. Yes, there for some folks that were doing a reverse shoulder replacement, yeah, they have a large mass of rotator cuff care and they don't have a rotator cuff in place. For other folks, we're doing a reverse shoulder replacement for other reasons, advanced arthritis that has significant deformity, for example, but they still might have their rotator cuff in place or part of the rotator cuff in place. So, one thing, and it varies from surgeon to surgeon is, there's a cuff sparing reverse shoulder replacement where rather than take down the rotator cuff, you try and preserve as much of the rotator cuff so that it's there at the end of the case. It's just an additional muscle that can provide additional strength and range of motion. Another example would be whether or not to repair the subscapularis muscle after reverse shoulder replacement. That's a muscle that we commonly have to take down on the front of the shoulder to get access to the shoulder joint. And it's debated in the studies and amongst surgeons how much repairing that muscle at the end of the case helps with the patient outcomes. But that's another structure that we could look to preserve. And some surgeons theorize that preserving that muscle might give you better rotational range of motion when the patient heals. Other surgeons might argue that by packing that muscle down, it constrains the shoulder a little bit and makes it a little bit more stiff, for example, with external rotation. So there's trade-offs for everything that we do. And, a lot of times it's a feel thing. If it depends on what the muscle looks like. It depends on how much you're stretching it at the end of the case to repair it. And these all kind of weigh into how you proceed with that patient.
Yeah, ultimately, at the end of the day, N is always going to equal 1, right? Like, there's all these different guides and recommendations, which are phenomenal to have as a blueprint, but there's been multiple times where the patient in front of me doesn't match what was written, and it's like, well, I need to use these as principles, but apply them in relation to what this patient needs right now, right? Like, one of the best examples, I'm presenting on this case in spring 2026, but this individual had bilateral adductor procedures done at the same time. And I was like, man, like I've seen like unilateral, but like both at the same time, like this changes things. Like where do I go from here? So it's cases like that, and obviously again all these other variables and factors that we discussed that make every patient so unique that it's always a case by case thing for me at the end of the day.
Yeah, I think you nailed it on the head. Every patient truly is unique, and yeah, I think you need to take those factors into account when you're coming up with the treatment plan for these patients. And there's just really no cookie cutter approach that fits for every patient. You do need to tailor it, and there are certain things that we can modify for the same exact surgery. We can modify little factors for one patient to the other, so that they to help them achieve their goals and give them a better outcome.
Absolutely. If you are gonna see these patients return to sport that way, whether that's shoulder arthroplasty, hip arthroplasty, what typical timeline do you tend to see for them? About the 9, 10 months mark or close to a year? Or
Um, Probably sooner than that. Let's say, for example, a hip arthroplasty. Commonly patients, usually by the 3 to 4 month mark, especially if they're a more active patient looking to get back to the sport, a lot of their healing has occurred at that point. So I think at that point you could start ramping up their activity level. Some patients, might be even sooner that, hey, I'm feeling great. I'm walking normal. I feel like I can push it a little bit more. Other patients, it could be a little bit longer for them to wake up some of those muscles around the hip. So once again, it's an N of one. Everybody is a little bit different. Um, in terms of kind of ramping back up to the sport, I think it's important that you do in a slow, moderated fashion. Oftentimes these athletes, they want to go, 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 and they feel great, but you need to slow them down a little bit so that they don't re-injure themselves getting back to the sport. So oftentimes that's more of the challenge is slowing them down rather than speeding them up.
yeah, that makes a lot of sense, and it can be difficult to do that. It's like it's a lot easier, I found, to encourage people to hit the gas than it is to get them to pump the brakes and slow down. I mean, I think that's natural in the athletic population. People just wanna go and do more stuff, but I feel like we could probably talk about that all day long, Dr. Kerr. It's been an amazing conversation. Is there anything we missed as we were chatting or anything else you really wanted to bring up for those listening?
I think this is a great talk. We talked about a bunch of things here, and I love what you're doing here with the podcast. I appreciate you bringing me on.
Absolutely. Yeah, no, it's been amazing to have you and to have you share your insights that way. For people who want to find out more about you and your practice, where can they find you at online and all?
Yeah, so they can go to titlehealth.org and search me there. I have a website there, and that would probably be the easiest way to find out about my practice. And if you wanted to schedule an appointment, you could go through that as well too.
Seaford in Millsboro, Delaware, correct?
Yep.
Awesome. We'll link to all of that in the description below. That way, if you didn't quite catch it, you can just click there and get in touch with Dr. Curley and his team. This was awesome. Again, thank you so much for your time, Dr. Curley.
Thank you.